Hello and welcome back to Synapse Sessions. Today I'm joined by Dr. Matthew Antonucci. Dr. Antonucci, how are you doing today?
Hey, Dr. Garcia, I'm great. Thanks so much for having me today. I'm really excited to share at Synapse Sessions 2020.
Awesome. Thank you. We're excited to have you here. I can see that your topic is, the presentation is called The Roll Axis, the Third Dimension of Vestibular Rehabilitation. So I think we're going to be talking pitch, roll, yaw type stuff, right? Is that correct?
Yep, that's right. We're going to be talking about vestibular rehab and all the different ways that you can do it and why one differs from another.
Okay. So what inspired you to pick specifically look at the roll aspect of it? What inspired you to do that?
Well, a lot of vestibular rehab has traditionally been done in the pitch and the yaw planes, which we'll talk a little bit about today in a little while. But the roll plane is kind of like this, like we said here, like a third dimension. It's an unexplored dimension because, quite honestly, up until recently, we haven't had the technology or the tools to be able to straightforward address it or even assess it. So over the last couple of years, we've developed a whole lot of testing that has been able to give us some insight into the roll axis and otolith function, which we'll talk about a little bit, but also the therapeutics associated with it. And from a clinical perspective, because I'm still definitely in active practice, we see a lot of patients that have these otolithic based decompensations that we haven't been able to address until we were able to really address the roll axis straight on. So I'm excited to kind of chat with you a little bit about how we do that and the science behind it.
Yeah, no, this is fascinating to me because you're right. The roll axis is like you kind of really understand pitch and yaw really well, and rolls it's just a little bit more difficult. It becomes a little more unclear. I don't even want to say the word vague, but I just feel like I haven't gotten like that definitive, like, this is the mechanisms for all this stuff. So I'm curious to see if you could shed some light on that. And you know what? I'm going to get off the stage. The stage is going to be yours. I'm going to come back at the end and we'll have a little chat. All right, Dr. Antonucci?
Okay, that sounds fantastic. Thanks a lot. Welcome, everybody. I just want to say thank you for joining me here today and on my Synapse session presentation. Just a couple disclosures. I do have financial compensation from Plasticity Centers in the Carrick Institute. I'm a faculty member and also a clinician at Plasticity Brain Center. So just those were my financial disclosures, nothing else besides that. So now that we got those out of the way, let's get on the roll here. Really interesting quote from Robert McCrae. He's a PhD over University of Chicago. He says, an accurate view of the external world depends on the ability to distinguish between sensory experiences produced by external forces and sensory events that are produced by self-generated movements. So what this actually means is that the vestibular system is the foundation for you to be able to know where you are in space and where space is in relationship to you. And many individuals have suggested that is the foundation of life form. We talk about this in our receptor-based essentials program, where we say that realistically, the only reason why we have a brain is to be able to perceive the environment, interact with it so that we can survive and reproduce. And like we said, at the foundation of that is vestibular function. And we're going to talk a little bit about the science and the research behind it that allows us to agree with that so that we know how important the vestibular system and the vestibular apparatus, its integration truly is. So I think you guys are going to be really excited. This is a pretty in-depth presentation, taking a very complex subject and trying to make it as easy to understand as possible. I've got over 25 references in here, all with their PubMed ID. So as we go along through this, if you just jot down the PubMed ID, you can go on PubMed, plug in the number, view the entire paper where we got this information from. None of this is opinion except for when I say, hey, this is my opinion. This is really going to be a presentation of the literature supporting how the roll axis is intimately involved with human existence and how we as clinicians have a responsibility to assess it and address it if there's any types of dysfunction. We're even going to get into a patient case that we had that's a little interesting, and you would never expect this patient to have the problem that they have. And I think you'll really enjoy kind of understanding a little bit about what happened with that patient. So the vestibular system has been labeled the precocious sensory system. It develops so early. As we know, precocious means it's early to the party, right? So here's a table that I created with references on the right side that talks about how long after conception a certain function happens, and then the author of the paper and the PubMed ID to do it. So we often hear this conversation that the vestibular system develops really early in life. And the in life is a controversial topic, especially in politics and things of this nature. But after conception, there's a certain period of time called gestation where the nervous system develops. So 7 weeks after conception, the vestibular epithelium and hair cells that we know so well about the vestibular system are observable with scanning electron microscopes. So that's 7 weeks after conception. At the same exact time, there's otoconia or ear stones that are present inside the utricle. So it's 7 weeks after conception, before most people know that they're pregnant, the otoconia and the utricle, as well as the vestibular hair cells and the epithelium, are present. 9 weeks after conception, just 2 weeks later, vestibular synapses form. So the synapses between the cranial nerve 8 and the vestibular nuclei begin to form, as well as the hair cells onto the cranial nerve 9. 12 weeks after conception, just merely 3 months, the connection between the vestibular system and the oculomotor system begins to develop. 17 weeks after conception, the vestibular labyrinth has actually reached adult size. That is almost mind-blowing, right? So that's halfway through pregnancy. Your vestibular apparatus has reached adult size, and 20 weeks after conception, cranial nerve 8 is the first cranial nerve to completely myelinate. So this is the first cranial nerve to finish its myelination process. So that would suggest to us, man, this must be really important. If it's fully myelinated first at 20 weeks after conception, that must lay the groundwork for a lot of things to come. And that's absolutely accurate. It's the groundwork for a baby or a fetus to know whether they're up or down, moving forward and backwards, bouncing up and down, turning around. And some research even suggests that the vestibular apparatus or vestibular dysfunction helps a baby rotate so that they're not in the breech position. So how interesting is that, right? So maybe a baby who's born breeched, maybe they may have vestibular dysfunction right off the bat, and which would be an indication maybe for us to assess them. 21 weeks, a week later, the vestibular nuclear complex is functional. So before you're born, your vestibular system is fully functional. You can understand why somebody might call this the precocious sensory system, because it really does fully develop before we're even born and lays the groundwork for so many sensory systems to follow. And that's going to be the basis of what we're going to dive into today. So the first kind of question is, well, why the vestibular system? Well, this is the why. The why is because it does set the groundwork for all sensory systems to follow and allows us to have this perception of where we are in space and where space is in relationship to us, so how we can navigate it, so that we can interact with it. So now we'll talk a little bit about the vestibular system, because not everybody here is way down the educational path of neurology where they understand everything we're talking about. And I have no shame in saying this. It was all the way through chiropractic school that I realized the vestibular system wasn't actually in the brain. The vestibular system itself, or the vestibular apparatus, was actually in the inner ear, carved out of the petrous bone of the temporal, petrous portion of the temporal bone. And that was just something because it just went over my head. So let's not go over anybody's head. Let's start with the groundwork, and we'll make our way to the more complex stuff. We're not going to spend a whole lot of time on the anatomy and physiology, because let's face it, you could pull up a YouTube video and probably get that just as good as I could deliver to you, if not better. So we'll just kind of hit the highlights of the things that we need to understand in order to understand the role playing. So the vestibular system are receptors designed to detect head acceleration. That last term is very important. It's not semantical, head acceleration. Our vestibular system does not detect head position. It only detects our head movement. So if we're completely still and in a gravity-free space, your vestibular system is completely dormant. It has zero activation because it only detects acceleration. So you may have asked, well, why in a gravity-free environment? We're going to talk a little bit about this a little bit later, but gravity is actually an acceleration force. Remember, whenever we describe acceleration, we describe it in units per second squared, right? So it could be meters per second squared, it could be feet per second squared. And a lot of people know that gravity is equal to 9.8 meters per second squared. So we are actually being accelerated at 9.8 meters per second towards the earth every second of our life. However, most of the time our feet are in contact with the earth, so we don't necessarily fall to the earth. But if you were to jump out of a plane, or if you were to lose your balance, you would fall to the ground at an acceleration rate of 9.8 meters per second squared. That's a linear type of acceleration, but we also have rotational types of acceleration, which is more a responsibility of the labyrinthine system, which we'll talk about right now. So here's the human vestibular system. You have the ear, the external auditory canal, you have your eardrum, you have the ossicles that interact with the eardrum that are all part of the hearing structure as well as the cochlea. But where you see that little snail-shaped structure, that's the cochlea, and where you see where it has kind of like these round antlers that come off the snail's head, those are the semicircular canals or the labyrinthine system. All of those are filled with a fluid that allows us to detect motion. The fluid is viscous, so it lags behind motion, and it has hair cells that stand out into the fluid. So whenever we turn our head in different directions, an angular type of movement, the semicircular canals, they move and the water stays still, the fluid stays still, and it depolarizes hair cell that says, hey, you just moved your head. You just accelerated and you're not accelerating anymore. And those create an action potential, travel through the vestibular ganglia, vestibular nerve, into the internal auditory meatus, into the brain stem at the pontomedullary junction there where we see the vestibular and cochlear nucleus exist. Okay, so that's your general vestibular anatomy. Now let's talk a little bit about what these semicircular canals actually detect. Top left-hand corner there, you actually see the vestibular epithelium with the hair cells and a gelatinous membrane with otoliths on top of it. That is the otolithic system, which we talk about in just a second. On the bottom, you see a structure that has a vestibular epithelium as well, has hair cells as well, and has something called a cupula, which is once again like an encapsulated structure that has hair cells inside of it that allows us to detect fluid movement past that cupula. So the way that the semicircular canals are designed is they are specifically designed to detect angular or rotational movement. You can just imagine with a structure that is round like that, if you were to turn your head, the fluid inside of it would move opposite direction of the head. Think of it like a bowl of Cheerios, right? You're holding a bowl of Cheerios and you turn that bowl of Cheerios, the Cheerios and the milk actually stay still while the bowl moves. So that contrast is what bends those hair cells and tells you that you just accelerated in rotation. Now there's three different planes of rotation that humans move their head. Pitch, yaw, and roll. Pitch is movement forward and aft. Yaw is movement right to left, and roll is going to be lateral flexion left and right. Now, we specifically said head because these vestibular structures do not detect body movement. They'll detect body movement if your head is moving with your body, but if your head is still and your body is not moving, these structures will not detect any motion. That doesn't mean you won't perceive it, doesn't mean you won't have vestibular central activation. It just means that these structures did not detect that movement. And here's a great example of how these hair cells work inside of these vestibular labyrinthine systems. And once again, these are all slides from our receptor-based essentials program where we kind of talk about this in a little bit more depth than we're covering with it today. But I just wanted to make sure that we had the fundamental groundwork to get to where we need to go. So you can see this individual sitting still, that cupula is not deformed at all because the head is not moving. And as soon as that individual rotates its head, you see that the fluid moves past the cupula. Now, a lot of people look at this diagram and they say, wait a second, something doesn't look right. And if you're saying that to yourself, congratulations, you're paying super close attention. There's something wrong in this picture. And I'll let you take a second to see if you can figure out what is wrong with this picture. Okay, so if you said that that person is rotating their head to their left and the cupula is deflecting to the left, that's backwards, you've nailed it. So if we understand this appropriately, when that head turns to the left, what will happen is that whole semicircular canal will rotate to the left and the cupula will deform to the right. So that is an error that this artist or this graphic designer made, but it's a great illustration point to see if you're paying attention, if you understand the concept. So that is how these semicircular canals work. Now, there's a big misconception that a lot of people have. And this is from a decade in the field here and talking to a lot of individuals, a lot of scholars, and a lot of people who are diplomates and really experienced in this. And they'll say, I'm activating a canal right now. Based upon what I would say, you would say, hey, wait a second, you're wrong. Okay, I'm activating a canal right now is accurate, but I'm activating a canal right now is inaccurate. So when we move our head to a fixed position and we remain in that fixed position, there is no activation of the receptor. The activation of the receptor only occurs during the movement. Remember, let's go back to where we started. These are acceleration detectors. So when acceleration stops, they are no longer detecting movement, with maybe a little asterisk of an exception, which we'll talk about in a second. So at rest, here's a great example of how the system works. You have your right vestibular apparatus and your left vestibular apparatus. At rest, because we exist in gravity, there's a certain amount of activity that's always there, and it's about 80 to 100 spikes per second. So spikes are basically an example of action potentials. So you can say this differently. There's 80 to 100 action potentials per second. That's the baseline resting rate. And the way that these vestibular canals work is they're a push-pull relationship. So when you turn your head to the right becomes activated and the left becomes inhibited. Or to say it differently, the right depolarizes and the left hyperpolarizes, it becomes farther away from its activation threshold. So you can see as this individual turns their head to the right, we have 200 spikes per second and nearly 0 spikes per second on the left. The right is excited and the left is inhibited. So asymmetrical input indicates to the central nervous system that the head is moving to the right. So now that we really understand from a high level how these vestibular labyrinthine systems work, let's talk a little bit about the vestibular otolithic systems. Very similar design, hair cells, vestibular epithelium, and this time instead of a fluid, we have a gel. Okay, in the top right-hand corner, you'll see that you have your vestibular epithelium, you have your hair cells, you have this blue gel-like structure, and you have these little, what look like stones that sit at the top of this gel-like structure. The stones are literally called otoliths, from the Latin to mean ear stones. So these are ear stones. These are also called otoconia. And the purpose that they serve is to weigh down this gelatinous structure. So you have hair cells with gel with weight on top of them. And this is purposely designed to create a shearing motion between the epithelium and the gelatinous structure. So when you move this way, you pull ahead of the hair cells and ahead of the gel, and the gel bends those hair cells to say, hey, you're moving in one direction or another. And when you stop moving, the gel catches up and now you're stagnant, you're not moving. So that is how these work from a very basic perspective. Now, what you'll see in the top picture there is there's an individual with their head still and head upright. The otoliths and the hair cells are straight up and down. There's no deformation. Therefore, that person is not experiencing any movement. Now, what is really different about these otoliths compared to the labyrinthine system is these detect linear acceleration versus angular acceleration. Remember, the labyrinthine system detects rotational or angular acceleration. These detect linear acceleration, and gravity is one of those forces of linear acceleration. It pulls us straight towards the earth. So when we look at the bottom picture, when that individual flexes their head forward, you can see that those otoconia or the otoliths, they basically fall towards the ground at 9.8 meters per second squared. So they are pulling down towards the ground, they're pulling on the gelatinous structure, and they're bending those hair cells to say, hey, you are going down towards the ground now, you're moving forward. Now, here's the problem. There's a bit of sensory ambiguity between the otoliths functions. So the primary otolith function respond identically to inertial motion stimulus, meaning that they respond the same whether you're moving forward or if you've tilted forward. So one of the problems they cannot do is they cannot detect tilt from translation. Let's go back one slide. So look at that bottom individual again and try to forget that you see his head inflection. I'm going to use my fingers as a representation. Let's just say that his head is upright and those hair cells are bent this way. If his head was upright and his hair cells were bent that way, he would feel like he's moving posteriorly, right? Because there's an acceleration posterior and those hairstyles start to bend as if he's being thrusted backwards. So how does your brain know if you're being thrusted backwards or if gravity's pulling you towards the earth? Those are dramatically different body perceptions. To be pushed backwards or to be pulled your head forward are dramatically different. So our brain has to be able to tell the difference between the two. Otherwise, you're in trouble because what type of motor patterns do you create when you're falling backwards? Well, things to brace a fall, maybe to catch yourself from a fall. What type of motor patterns do you have when you're falling forward? Well, once again, motor patterns to brace yourself from falling or to catch yourself from falling one direction or another. You're also going to engage spinal muscles differently. If you felt like you were falling forward, you would engage posterior neck muscles. But what if you were actually being pulled backwards and you engage those posterior neck muscles? Well, you're definitely going to fall backwards. You can see how this presents quite a challenge for the brain, because if you take one receptor, just these otoliths, and take its raw information bringing in, it's slightly ambiguous where we can't really detect it. So they require input from the semicircular canals. So this angular type of motion in relationship to gravity, whether it's forward, backwards, or roll right and left, which we'll get into in a second, requires input from the semicircular system, which is why roll becomes a very complicated topic, because we're not really talking about one thing in isolation. We're really talking about two systems working together to create the illusion of whatever it is that reality is for that person. And I use that very purposely because when you have individuals that have issues or injuries to the system, it really is an illusion that's not really true. Life is just an illusion. You know, everything that's in the world we perceive, our brain interprets, and then we make actions based upon that. So you can really get deep and philosophical and say that nothing is truly real because everybody experiences everything different. So there is no permanency, there is no real in the world because it's all based upon our perception. But we won't go there today. The vestibular system contributes to much more than just balance. The vestibular nuclei influence many important functions in addition to balance and posture, things of eye movements, thinking, spatial awareness, and autonomic function. So here you see a color-coded diagram of the vestibular nuclei, in which there are four, and you see that balance and posture makes up about 50% of them, but the other 50% is kind of like a montage of autonomic control, cognition, eye movement. So all of these things work together because for the longest time we thought, when I say we, the scientific community thought this vestibular system was only involved in balance and posture, all the way from the 1800s when Florence saw these pigeons standing on 2 feet, and then he saw them maintaining their balance, and he kind of got a little exploratory and found out that these vestibular apparatuses allow these pigeons to walk on 2 feet. So we assumed that humans have the same thing, and it's existed that way for over 100 years. That we thought the vestibular system was only involved in balance. It's just been in the last about 2 decades that we've really established that there's so much more than balance to the vestibular system. Now, the other thing that I kind of get semantical about is the difference between the vestibular apparatus and the vestibular system. If you think of an audio system, which many of us have in our homes, right? We have speakers and we listen to music. It's a system because it's not just a speaker, right? It's a speaker, it's a wire, it's an amplifier, it's a receiver. That creates a system. A system, you have to have multiple structures, multiple pieces to constitute a system. A system can't be one thing. So when we talk about the vestibular apparatus, it's just one part of the system. The vestibular system itself is actually really pervasive. There's so much to it. So here's a great diagram that illustrates not even fully the integration of the vestibular system, because it's not showing you here the integration in the cerebellar structures and other areas of the brain, but it allows us to get a little bit of a walkthrough of what that might look like. So if we have the labyrinths as well as the utricles or the otoliths, those go through the vestibular nerves to the vestibular nuclei. We have communication from there into different parts of the cerebellum, like the cerebellar flocculus, the cerebellar vermis, where the vermis is very much responsible for midline control of body parts, spinal articulations, particularly of the neck and mid spine, and then the cerebellar flocculus, which is really responsible for looking at eye movements such as tracking and also vestibular aspects and VOR gain. So, or vestibular ocular reflex gain. So all of that integrates there. And there's also a whole lot of evidence that supports that the cerebellar flocculus and vermis regulate saccades. They also regulate emotions. They regulate autonomic functions. They even have direct communication with the hypothalamus to regulate pituitary axis and pituitary adrenal axis, pituitary gonadal axis, pituitary thyroid axis. So the cerebellum really regulates everything, with one of its primary inputs being the vestibular structures. We also have integration there into the pons for oculomotor function, the midbrain for oculomotor function. Also, we know that there's dopaminergic and noradrenergic cells in the midbrain that become activated whenever there's vestibular stimulus. We have structures that allow us to hold our eyes on target in the vertical plane and also in the horizontal plane. There's integration into the thalamus, and the integration into the thalamus is such that it really has an influence on our thalamocortical oscillatory rates and how well our brain perceives the world. It essentially turns up the gain or the volume of our brain to our environment. And that integration in there into the parietal insular vestibular cortex, and long word, parietal meaning sensation of your body, insular meaning your sensation of your inside, and vestibular cortex is pretty straightforward. This is an integration or sensory association area that allows us to associate all of our senses to, once again, back to where we started, know where we are in space and where space is in relationship to us. So we also have this ability to navigate into a world and execute appropriate behavioral and motor responses, depending critically on our capacity to construct an accurate internal representation of our current motion and orientation in space. So our ability to move throughout this world is fundamental to our constructs of space. And the next quote from Freire is that no unimodal vestibular cortex has been identified in mammals' brains. Rather, vestibular inputs are combined with many sensory signals in the cortex. This arrangement suggests that vestibular input could influence processing of other sensory modalities. This, once again, dovetails in what we said before. The vestibular functionality is the foundation for many other sensory modalities. And the final one from Lackner, 1992, and I want you to remember this because we're going to come to this all the way at the end of this presentation when we start talking about what do we do to treat these types of conditions. The location of objects in extrapersonal space requires an integration of proprioceptive, visual, and vestibular signals. So in order for us to have good perception of space, we need integrity in those three systems, and that's how we can affect somebody's perception of where they are in space. It's a bit controversial about peripheral versus central issues or decompensations. However, the controversial aspect of it has become much less controversial. Brandt has done a lot of work in this area, looking at bedside examinations such as things like head impulse tests, oculomotor functioning, looking at gaze nystagmus, or even skew deviation, which we're going to talk a bit about today, to reliably differentiate between central and peripheral syndromes. One of the other ways to really differentiate between those two, peripheral syndromes are most oftenly acute onset. They happen really, really quickly, with the exception of a couple of things like stroke and some others. But if you have a rapid onset of vertigo and dizziness, that's probably peripheral in origin. That's the other thing. Often peripheral issues present with dizziness and vertigo, where central lesions sometimes don't have dizziness or vertigo associated with them. There could be many other things associated with them, and that's where the next bullet point comes in. Disorder of higher vestibular functions involve more than one sensory modality as well as cognitive domains. Example, orientation, spatial memory, and navigation. So you can have a chronic central vestibular decompensation that changes the way you perceive your orientation, left from right, up from down, forward from backwards, navigation, or spatial memory. Where did you put your keys? And navigation, how do I get home from here? Where did I just come from? So those are really important to know. So there's two dimensions of vestibular rehab that we currently look at. This is the yaw and pitch plane. So here you see an individual on the screen in the video doing some pitch-based vestibular rehab exercises. And then she's going to move into yaw-based vestibular rehab exercises. So these are the two dimensions in which we currently operate in the majority of the time. Vestibular PT is a very large specialty in physical therapy. There's many providers around the country that are very good at doing vestibular rehabilitation exercises, customizing them for their patients, their clients, based on utilizing these two dimensions, and they get a lot of great results. The question is, what happens when these two dimensions are addressed and the patient is not well? That's where we come in with this role playing. What does vestibular rehabilitation look like? This is straight out of a reference article from PubMed. Vestibular rehabilitation includes vestibular exercise protocols, management of vestibular suppressant medications, and general conditioning and patient instructions. Exercises should be static and active, posture and balance, head and eye coordination, and symptomatic dizziness being addressed. Exercises include practice with standing, walking, and turning, head movements during visual fixation, and visual target changes. That is vestibular rehabilitation in a nutshell. We don't see any fancy tools like big chairs. We don't see any complex maneuvers like non-BPPV rolls and things of this nature, because the state of vestibular rehabilitation is just that. They're addressing posture, balance, eye coordination, and symptomatic dizziness through exercises of standing, walking, and turning with their head. But what about roll? So we need to talk a little bit about roll, right? So it's the third dimension of vestibular rehabilitation, looking at this lateral flexion from side to side. And it is quite a complex maneuver. And we see dogs doing it. And we think that it's so cute. And we're like, oh, look at them. But realistically, it is a pretty complex task. So the question is, with roll, how do we perceive tilt? And this is going to help us navigate to where we need to go. So as we stated earlier, gravity always pulling straight down at 9.8 meters per second squared. So the individual on the left, you can see that their center is where the blue line is. Gravity's pulling straight down, and they have no rotation of the eyes. However, as soon as they start leaning off that Earth-related vertical axis, we start having a change in the direction that gravity is pulling them. You can see the blue crosshairs, which shows they're perpendicular, straight up and down a perpendicular. And we see their deviation off of that perpendicular. It looks to be about 10 or 12 degrees. When we have that angular rotation, we have we have unilateral, both anterior and posterior semicircular canal activation due to the angular forces associated with that. And we also have a linear force associated. So I want you to look at that what would have been the parallel to the ground or perpendicular to the head. You see how it starts to tilt. Think about if you had a glass of water on that table. What would that glass of water do? It would slide off the table because it's being pulled towards the ground. So that's where we have a combination between our angular forces and our linear acceleration. So the otoliths detect change in gravitational acceleration, angular movements such as the lateral bending cues, inertial fluid movement in the anterior and posterior semicircular canals. The neck muscles also detect stretch. And then there's also what's called optic flow mechanism causing retinal slip. So we start to see the world turning as we move our head. That indicates to our eyes, with special cells in our eyes, to communicate with the cerebellum to say, hey, you know what? Either the world is turning or I'm turning. Neck muscles, what do you think? Neck muscles say, hey, it feels like you're turning. Okay, let me get confirmation from the otolithic structures. Yeah, we're either leaning to that one side or we're getting pulled to the opposite side. Let me query the semicircular canals. Semicircular canals, are you receiving any acceleration? Yeah, we're actually getting acceleration, not just in the anterior canal, we're getting it also in the posterior canal, all on that right side. And combined with those information, those pieces of data, we say, oh, we're tilting our head. You can see how complex it is, and it happens instantaneously, like milliseconds, so quickly. These are some of the fastest pathways in our central nervous system to detect these. And you can see if just one thing goes wrong, it could lead to some pretty bad problems. So aberrant vestibular information generates error and elicits activation in areas related to defense, autonomic, and somatomotor responses. So what you can get out of this is you can get anxiety, you can get changes in blood flow, you get changes in muscle tone, you even can get changes in voluntary strength. So looking at the diagram on the side, you see a couple of structures that are really important. Number one, as we talk about receptor-based essentials, that parabrachial nucleus. This is the ultimate sinister, it's just the most sinister part of our brain. It's so pessimistic. It thinks that everything in the world is going to kill you. And it's a defense mechanism. It's a quick and dirty processing system that says when information comes into your brain, hey, it's got to be bad, get on defense, unless the rest of the brain says that's okay. So the first thing that happens is that vestibular nucleus sends information to that parabrachial nucleus saying, uh-oh, there's something wrong here. Triggers the amygdala, which assigns a fear response to it, communicates with the posterior insula saying, hey, you're feeling this. And then it communicates with the rest of the brain to see if that makes sense based upon the rest of the context of sensory information. And if everything goes according to plan, the defensive mechanism becomes active and we have these defensive motor responses, which is a problem for someone that is not experiencing actual error, right? If it's somebody that's just sitting on a couch talking, or someone that's just walking, or somebody that's trying to work out at the gym, and this process is happening, well, we're going to have, once again, negative emotions. We're going to have claudication, maybe, where they're not going to be able to use their muscles so well because they're not getting good blood flow. Because let's face it, if your brain thinks you're falling over to the left, you're going to take blood flow and move it all to the left side of your body so you can activate those muscles. Therefore, you might get claudication on the right side of your body. And if you're not falling over, that's not a good thing. Changes in muscle tone, you can have hypertonicity or hypotonicity. We see compartmental changes in reflexes based upon people's perception of where they are in space. And voluntary strength, we can't recruit muscle patterns the way we want to if they're being hijacked by a reflex. So here's a patient that we had a little while ago, and they presented with a loss of strength. So she was a strongman woman. Okay, so she competed in female strongman competitions, and she's basically saying, "I can't do anything with one of my legs. It's the most bizarre thing. I can walk around, I can walk, but whenever I try to exert force with my leg, it's just nearly impossible." So let's see what she has to say.
Hi, I'm Pamela Paul, and I'm here at Plasticity Brain Centers because as a strong woman, I really need to be able to use my whole body to compete, and I was having some trouble driving through my left leg and getting the signal to translate into movement. So I'm hoping that they can restore my function, and we'll be testing that at the end of the week. Okay. That's a lot better.
I gotta keep up.
I can't accelerate anymore, but... Oh, there you go!
Awesome.
Starting to get a little tired, but no, that was a lot better.
How does it feel?
Much better.
Oh,
Much better.
Awesome.
I just pushed Dr. Link's little SUV. Not used to pushing something quite that small, but it was a good way to test to see whether the leg drive has returned. And it felt much, much better. I was able to get that leg to respond and drive the car. Maybe not my fastest push ever, but definitely on the road back to competition and feeling very positive about the week.
Okay, so this was an individual who came to us, like you said, with loss of strength in one of her legs, and she couldn't do any exercises. She certainly couldn't compete. And one of the things that we found is that one of the only things that she had going on is that she had this giant skew of her vertical. When we tested her in a certain test, we'll show you in a little bit, she was like 25 degrees off of vertical. She essentially thought that she was over here all the time. And she was creating muscle patterns associated with that. She had like zero posterior compartment myotactic stretch responses on her left leg. And she had hyperreflexes on her upper extremities on her right side. So you can see she was kind of all off. So we addressed her perception of role playing through otolithic based mechanisms. And you can see towards the end of the week, she's able to push that SUV with relative ease. And she said it wasn't the heaviest thing she ever pushed. She's not usually used to pushing something so light, but she was able to do that and sees that dramatic change in a short period of time because we were able to address the perception of where she is in space and space in relationship to her. But these vestibular concomitants also have pervasive effects. There are conscious, subconscious vestibular deficits that cause changes in the hippocampus. So whether you can perceive that things are off, or even if you cannot perceive that things are off, we know that there's a cascade of reflexes or cascade of activities that occur as a consequence to having poor vestibular integrity. And probably the scariest of all of them are the way that these vestibular pathways affect Amon's horns. So if you may not know what Amon's horns are, this is like area CA1, CA2 of the hippocampus. These are the areas that in the entorhinal cortex that are not responsible for olfaction. But what they do is they transfer information from the hippocampus to the neocortex and take information from the neocortex and store it back in the hippocampus. So it really underlines and underpins long-term memory. And it just happens this area CA1, CA2, straight where these vestibular projections occur, are dramatically affected early in Alzheimer's disease. So this is the part of the brain that starts to degenerate with Alzheimer's disease first. So really interesting to see that vestibular concomitants can affect the area of long-term memory. Now, what else this also does is it can deteriorate long-term memory, but it can also set up plasticity in spatial relationships based upon your experience of where you are in that time. So, for example, if you were a paratrooper jumping out of airplanes in the Army, and every time you jumped out of the plane, you knew you were getting into battle and you were going to be shot at. What can happen is anytime you're in a vehicle that happens to have a dip, or anytime you're in an airplane that happens to have a dip, you would activate autonomic circuitry that is associated with a fear response as a consequence to that, not emotional memory. It's a physical sensory type of memory that occurs that triggers something like PTSD is associated with movement rather than thoughts or environmental circumstance. So the integration of this vestibular structure into the hippocampus is an area of study. And you can see O'Hara, this paper was from 2020, fresh, hot off the presses. And the graphic there in the bottom was from Hidier in 2014, but all talking about the same stuff. So individuals with decompensations of the cerebral or cerebellar cortices may present with signs associated with tilt without even being in tilt. So here we have the same gentleman as you saw before, only his head is not tilted, but he's contracting neck muscles and he's rotating his eyes as if he were tilting to his right, or a contraversive tilt. So this can cause ocular torsion, it can cause skew, it's going to cause distortions of subjective visual vertical, which we're going to talk about how to assess in just a moment. It can cause neck tightness, spatial disorientation, particularly with visual suppression, and heightened vestibulospinal reflexes. So an individual who's perceiving tilt subconsciously, remember, these are not people who feel like I'm walking around crooked, they actually feel like they're straight when they're over here. But if you tell them to sit up straight, they can volitionally do this, but their brain is still perceiving tilt, and they're going to have reflexes associated with ocular torsion, neck muscle tightness, so on and so forth. So this could be a big contributor to neck pain. This could be a big contributor to limited range of motion, lateral flexion. It could be a big contributor to spatial disorientation and the like. So we'll talk more about that. So how do we test for these things? So we talked a lot about what it is, and how do you take this and put it into your practice? Well, we can start testing for otolithic disorders by doing the Parkspachowski 3-step test. And Wong in 2011 added one more step to this 3-step test. And if you remember, or maybe you don't know, Parkspachowski test identifies whether or not a skew deviation is a consequence of a muscle weakness or if it's from central dysfunction. So step one is to see if there's any hyperdeviation in primary position. Step two is if there's any hyperdeviation in lateral gaze. Step three is if there's any hyperdeviation with head tilt. And step four, which Wong and some others have introduced, to see if it resolves in the supine position. So if you have a skew deviation, meaning one eye is lifted up compared to the other, and when you lie down, it resolves, it's most likely central vestibular mediated from the otolithic systems. Now, on the right-hand side here, we've got a picture of a very infamous gentleman, Jeffrey Dahmer. We all know he's not so, let's just say, cognitively, emotionally healthy at the time. He was a cannibal. He was basically arrested for multiple murders and cannibalism, things of that nature. So, point being, this individual just did not have a good connection with reality. But one of the things that we see is looking at his mugshot is that we see a little bit of a distortion of his eyes and his head position. So what we see is his head is actually tilted to his left, but his right eye is elevated and left eye is depressed. We know with the left head tilt, we should have an elevation of the right eye and depression of the left eye. So this individual is actually perceiving gravity. He's interpreting gravity inappropriately. And gravity is there 24 hours a day, 7 days a week. And there are some theories, and partially my opinion, that this is part of the contribution of lunacy. If you remember, a lunatic, the word lunatic comes from the root word of luna, meaning moon. And we all think that people get a little crazier when the moon is full. But why might that happen? Well, when the moon is full and it's closer to Earth, especially if we have like one of those giant moons, the moon is closer to Earth and it's changing the way gravity is pulling on us, which can also change the way that our brain functions, and it changes the way we interact with the world. So it's a one day aspiration of mine to do studies on individuals who are violent crime offenders and looking at their ocular alignment in relationship to their head tilt to see if we can draw any correlations. Now, correlation doesn't mean causation. It's not that if your wife or husband has a skew deviation that's off like this, that they're going to eat you in your sleep. But it means that they're not perceiving gravity appropriately, and there's going to be some consequence of that. Maybe it might be double tasking, it might be balance, it might be spatial awareness, it might be focus, whatever might be influenced by this vestibular system, which is everything. So the first thing we can look for are hyperdeviations or skew deviations that resolve in the supine position. Another thing we can look at is subjective visual vertical. So there's something called the bucket test. Zwergel did a paper in 2009 that actually made this evidence-based, where you can literally make this for less than $5. You go to Walmart, Home Depot, Lowe's, your choice. You get a bucket. On the inside of the bucket, you cut out a piece of cardboard and put a vertical stripe on it, glue it to the inside of the bucket. On the back side of the bucket, you're going to get a string with a washer, and you're going to get a protractor and mount it to the back there so that you can determine what angle gravity is pulling down on that bucket. So you're going to align the protractor with the vertically oriented line inside the bucket so that they match up at 0. And you're going to place the individual's head inside of the bucket so that all they see is just bucket with line, starting with it at a horizontal. And I'll show you this in a second. Starting with the horizontal, you're going to start rotating the bucket until that person perceives that the line is vertical. And then on your side, from the practitioner side, you reference where that line is across your protractor, and that gives you your deviation off of vertical. So here's an example. So right now there is a line that's rotating. So this would be analogous to the line inside the bucket. And what you would do is you would keep tilting that bucket at a slow speed because you don't want to create any ocular flow mechanisms or optic flow mechanisms or circumvection with that line moving that all changes off. So you do it very slowly until the person says that it's upright. So we'll let this go for a little bit more. And let's just say that I'm looking at it and I think it's upright right now. Well, we know there's a variation or deviation off of vertical, and we would measure that. Or if we kept going past and I said, okay, it's right there, you would measure the deviation off of vertical with that. So that's how this subjective visual vertical bucket test goes. Another thing you can look at is we do this also in receptor-based essentials, where we look at the Unterberger's test, which is marching in place 50 steps with your eyes closed. Individuals with the otolith involved decompensation will often deviate laterally with Unterberger's test. And they're typically going to deviate ipsiversive to the decompensation. So if they've got a right-sided otolithic dysfunction, they're going to march straight to the right. If they have a left-sided otolithic dysfunction, they're going to march straight to the left. Now you're going to want to compare that with your subjective visual vertical. You want to compare that with your skew deviation to see if you've got multiple data points that suggest that that person has that issue. Another thing that we can do is, once again, this is a very basic receptor-based essentials test where we do finger, nose, finger testing, where you go back and forth between the patient goes back and forth between the examiner's finger and their nose with their eyes open as a control, and then repeat the test with eyes closed with head neutral for 10 repetitions and grade their accuracies out of 10. Patients will tend to be dysmetric ipsilaterally to their otolith integration failure. So they're going to have usually a vertical deviation off of that finger ipsilateral to the side of otolithic failure. So you can also do a therapeutic trial with this, which to me has the greatest impact on patients. The fact that you can do something that shows them that there's something wrong, and then immediately having a solution to it is really comforting for the patient, but also shows that you know what you're talking about. So a therapeutic trial, repeat the same test with eyes closed, with head and lateral flexion, ipsy versa to the decompensation. So if they missed on the right side, go ahead and tilt their head over to the right and have them do it again there. Now, if you really want to be super stellar and be a sleuth, take their head and laterally flex their head until it looks like their skew deviation is about normal. That's going to be the place where you have just aligned their vestibular input with their subconscious perception of verticality, and then have them do that there. Chances are they're going to get 10 out of 10 when they do that. So Luan did a little investigation into this 2013. There's the PubMed reference for you guys, so you can pull up the paper if you want it. So what patients have this? Well, chronic neck pain, scoliosis, migraine, affective conditions, TMJ, chronic regional pain syndrome, cerebral palsy, hypoxic ischemic encephalopathy from drowning or heart attacks, concussion, Parkinson's, ADHD, the list goes on and on and on. Maldeparkman syndrome, persistent postural perceptual dizziness, many more. So many patients have this. So what you're going to be shocked with is when you start testing it, how many of your patients actually have this poor otolith integration. Why? Well, because remember, it really depends on semicircular canal integrity, otolith integrity, cerebellar integrity, and parietal insular vestibular cortical integrity. It depends on a lot of stuff that's really important. And most of us are honestly not in that great shape. So how do we treat these role-linked disorders? Well, we treat them in the role plane or x-axis rotation. So role plane rehabilitation, the control of posture, perception of orientation of the body, and location of objects in extrapersonal space requires proprioceptive, visual, and vestibular signals. We've already repeated this. Remember, I told you earlier to remember it because it's going to tell us how to treat these conditions. This is Lackner, 1992. Well, we need to assess and address proprioceptive, visual, and vestibular signals in order to get somebody to perceive verticality the way it's supposed to. So where do we start? So effects of neck muscle vibration on subjective visual vertical, comparative analysis with effects on nystagmus. So this was a paper published in PubMed. There's your PubMed ID. And essentially what it says, with patients that have unilateral vestibular dysfunction, it doesn't say lesion there. It doesn't say they have a vestibular lesion. It says they have vestibular dysfunction or hypofunction. Vibratory stimulation to the neck muscles not only induces shift of visual vertical, but also enhances the generation of nystagmus, because you should have nystagmus with head movement if your vestibular apparatus is intact, if it has integrity. So just vibration on the neck muscles, addressing that proprioceptive component, will actually shift the visual vertical and enhance vestibular gain. Really cool. And not just vibration, any type of stretch. So this could be spinal manipulation. This could be myofascial release. This could even be active exercise, active stretching. Anything that's going to elicit large diameter afferents from those muscles will induce a shift of subjective visual vertical and also the way that the vestibular gain is established. Another thing we can start looking at is addressing the vestibular axis. So what I want everybody to do is I want you to stare straight in the middle of the screen. Okay. This is creating an optic flow-based mechanism. So we have a rotation of video while you're sitting still. So this is rotating clockwise, which is going to give you the illusion of rotating counterclockwise. And I want you to see what happens when the video stops. Okay, it's going to go for a little bit longer. A couple more seconds. And then I want you to see what happens when the video stops. Do you see how the video seems like it's rotating in the opposite direction now, even though it's still? That's not just an optical illusion, it's a vestibular illusion. So you can use the visual system to induce almost a augmented reality of head movement associated with the role plane. This is a very powerful tool. This is something that we often use with individuals that are not either a candidate for neck movements or whole body motion. So we can address proprioceptive, we can address visual, And then what we can also do is we can combine all three inputs. So this is the tool that we use at Plasticity Centers. It's called our MARC, our multiple axis rotational chair. And we load individual. Now, this is not actually a picture of it. This is an animation, because it just allows us to do a little bit better without patient consent and stuff like that. So what we actually do here is we're able to mount people on this device, and then we can turn them and roll. Okay, and this is significant because what we end up having is we have this acceleration in one direction, and then we have a suspension in horizontal position, which is going to be gravity pulling linearly straight towards the ground, which is going to be an intraoral, A-U-R-A-L, oral, from ear to ear acceleration, which really drives not only the vestibular apparatus, but the neck contraction. And as they rotate, the entire world is shifting. So this is not an augmented reality. This is reality. So that's an important thing to realize, is that doing this in a device like this is not synthetic. It's actually activating all the pathways in concert with each other. So why whole body rotation? And it's abbreviated here, HBR. Here's a couple quotes from a couple different papers. Most of the secondary vestibular neurons whose firing behavior was not related to eye movement control were better related to the velocity of body in space than the velocity of the head in space during passive whole body rotation. So we have these secondary vestibular neurons that actually respond better to movement when the entire body's moved compared to just moving the head. So whole body rotation itself has a bit of evidence to support that it has more vestibular benefit. Most of the neurons in the thalamus and the cortex that receive vestibular inputs are not related to eye movements and are sensitive to whole body rotation, and are also modulated during passive neck twisting. So saying that, because a lot of the vestibular function that we look at is regulating eye movements, such as the VOR. What we're talking about here is we're talking about more vestibulospinal activities, as well as the higher order vestibular consequences of cognition and things of that nature. They're more responsive to whole body rotation. And whole body rotation provides synchronized proprioceptive, visual, and vestibular input to facilitate activation of the parietal insular vestibular cortex and to induce Hebbian plasticity. Remember Hebbian plasticity. Donald Hebb, Canadian psychologist, says when two neurons, or in this case, three neurons, wire together, they fire together. So therefore, creating a better representation of where that person is in space and where space is in relationship to them, so that they can navigate this world, interact with it to promote survival and reproduction. So we're on a roll, but we're out of time. So I hope this kind of piqued your curiosity about this role play, and I hope you got some clinical pearls out of this. I hope that you got some applications that you can do. Now, this is yours to watch. You can kind of go through and view it as you will. If you have any questions, I'd love to be able to entertain your questions. So there's a QR code that you can scan with your iPhone. We're also accustomed to these QR codes now, but that'll install my contact into your phone book, so you can reach out to me. You can also find me at plasticity.co, carrickinstitute.com. One thing I will caution you with, be respectful of my time and your time. Don't email me with, I have a patient with Parkinson's disease, what do I do? Please reference some of the things that we talked about here today. You know, say that we did finger, nose, finger testing. Say I did subjective visual vertical. Say that you did an Underberger's test, and these were the outcomes, and pick my brain on it. I'd love to help you, love to consult with cases. We're here to serve. I'm here to serve you and your patients. So please don't be shy in asking questions. Just please make sure that you give me some background with the questions. With that being said, that's the conclusion of my presentation. I thank you. And I guess, Dr. Garcia, I'll hand it back over to you. Any questions?
Yeah, Dr. Antonucci, that was great. I really enjoyed it. And you did actually clear up a lot of things for me. And I completely understand why it is so difficult for people to understand the concept of tilt. It's not as easy as the other ones. It really isn't.
Yeah.
I mean, when you understand the way it's created, and it's kind of like I don't want to say multimodal, but it is the way it has many components to create it. It just becomes more, I wish it was one-to-one, like, oh, there's the tilt receptor and that's the way it works. And all we have to do is stimulate it. Let's find a way to do that. But hey, I do have a question. I was taking some notes. So, at Plasticity Centers, obviously we have the MARC, and that does, it does all the pitches, right? It's an amazing piece of technology. But not everybody has one of those, right? Some other clinicians will do barbecue rolls, or different repositioning maneuvers to try to get that type of input into their patient. Does it really matter? Like, are they all the same? Like, so for example, if somebody does a barbecue roll versus being able to use a pure roll in a mark, like, where is it different? Or when does one warrant the other? I guess that's a better question.
That's a great question. And anybody who's kind of gone through receptor-based essentials kind of knows the answer to this. If you can feel it and it feels different, it matters, right? So a barbecue roll will feel different than being in the mark and roll. Being in the mark and roll will be different than being in the mark and pitch or in another device and pitch. It's different than just tilting your head to the side. It's different than just watching a rotating video. If you can feel it different, that means it is different to your nervous system. So it does matter. Remember, our brain is such a fine-tuned instrument. It takes in all of these sensory signals and makes sense out of it and creates our reality. And we feel a mosquito on our leg and we feel the wind blowing on our face. Imagine if you were riding a bicycle at 20 miles an hour and you felt wind coming from behind you. How weird would that feel? Yeah. Right? That's an error, and that error triggers an autonomic response. And it's just not in concert with reality. So whenever we can do things in the most realistic way possible, it provides the maximum benefit. And that's my opinion, but also supported by some research. However, with that being said, you can certainly do other things. If you understand the fundamental mechanisms of this, a barbecue roll or something like that is a great example. You have these individuals in different positions lying still. So you're saying to yourself, wait a second, how can that possibly work? You're not even moving. But we have to revert back to our fundamentals. Gravity is accelerating that individual towards the earth at 9.8 meters per second squared. So when they're lying on their right side, they are getting pulled to the right as if they're falling to the right. Okay, so gravity can affect that. And then when you start doing the changes of positions, you're going to affect those things all differently. And when you're in other types of devices, or if you're doing different types of vestibular rehab, just keep in mind that what we want to do is we want to train the brain how we want it to function. If you want somebody to have good vestibular signaling and proper spatial awareness, sure, you can do that little pinwheel rotator video. But if you're not doing that with a vestibular input, you're not going to get the synaptogenesis that you need. So it all really does matter. We find that the mark is it's just the best of all worlds because it allows us to get all those signals working in concert. But not every one of our patients is a candidate for mark. We've got contraindications to doing it, where then we have to do the next best thing. I mean, we can get creative with this. Like, for example, if you have somebody that has an aberrancy with right roll and you find that you need to give them more right roll types of stimulus, you can do things like marching with right lateral flexion on heel strike. So whenever they place their heel down, they're going to laterally flex their head to the right, which is a normal biomechanical and physiological consequence. Every time we take a step, our head actually dips to the side of heel strike every single time. We're just exaggerating that and augmenting it to derive more proprioceptive input, more visual input, and more vestibular input through a natural mechanism. So there's a bunch of different things that you can do that become really effective. But for those of you who don't have the mark, you can still do this and you'll still get great results. I remember, and I'll conclude with this. Not the best. Dr. Carrick said a lot of great quotes, but one quote that really stands out in my mind is Dr. Carrick says that the work that we do should be able to be done in a parking lot with nothing but our hands. And that's the truth. We don't need all of this technology. But to say that is like saying, hey, you know what? We don't need computers anymore. It's just so convenient. Or it's like saying we can hop on a horse again. It's just so convenient to get in your car, whether it's electric or gas, whatever it is at the time. It's just so convenient to get in that vehicle and drive and not have to hop on a horse. So we can do this stuff without technology, but technology makes it easier and sometimes more effective for us.
All right. Beautiful response. And I want to thank you for taking it all the way back to the basics and fundamentals, because that made it easier to understand the more advanced concepts you were talking about later. And even your response to that question is, you're right. It's great to have a mark, but if you just understand the fundamentals of what you're talking about, there are different ways to approach that problem and still make some progress. Because, you can help somebody with a barbecue roll, but you really got to understand why you're doing it, what's actually happening, when to do it, and sometimes more importantly, when not to do it, right? It's like when not to do it.
Exactly.
So, Dr. Ducci, thank you very much for your time today. I think we're going to absolutely love this presentation. To everybody at home, we hope you enjoyed it and enjoy the rest of your day and the presentations here at Synapse Sessions 2020. Thank you, Dr. Antonucci.
Thank you.